hot, staying alive, staying alive. Hello, everybody. Dr. Ryan here, board certified specialist internist. Thank you so much for joining me, even as we undertake an exploration into the technique for the physical examination of a patient who has pyrexia or fever of unknown origin. If you haven't yet subscribed to my channel, I strongly encourage you to smash that subscribe button. All right, as usual, so step number one, introduce yourself, position the patient, usually fowlers or semi-fowlers, and obtain adequate exposure. Secondly, review the temperature chart. Have there been any temperature spikes recently? We're looking for the temperature above 38 degrees Celsius. All right, that was the oral temperature. Okay, and examine the sputum cup to check if there's any puddling sputum in there, any yellowish or greenish sputum that has been expectorated. Then you go on to the vital signs. Check the heart rate. Is the patient tachycardic? What about blood pressure? Is the patient hypotensive, which may indicate systemic sepsis and septic shock? How is the respiratory rate? Is the patient in obvious respiratory distress? Is the tachypnea? Is the rate above 20 breaths per minute? Are there obvious signs of respiratory distress? Alar flaring, sternocostal, intercostal recession, use of the neck muscles, right? Is there grunting? That applies more to the pediatric population. Then pick up the hands, check for any infarcts, any splinter hemorrhages, any ulcers, nose, Janeway lesions. All of this speak to, well, the infarcts can speak to bacterial endocarditis or vasculitis, but the splinter hemorrhages, those ulcers, the Janeways, all speak to infective endocarditis. Is there clubbing? We know the differential for clubbing is quite wide. Is the hypertrophic pulmonary osteoarthropathy, implying there could be a malignant underlying process? Is there Dupuytren's contracture, which happens in the setting of alcoholism? Right? Moving up, check for phlebitis, which is inflammation of the veins, any injection scars, especially in intravenous drug users, pigmentation, which implies Whipple's disease. Just look at the entire surface of the skin. We're looking for any infiltrates or any foci of infection, any carbuncles, any furuncles, any abscesses, any impetigo. Right, and lymphadenopathy is important, especially epitropic lymphadenopathy. And we know our different groups, like the cervical group, the axillary group, the femoral group, the popliteal group. Check for any tender or non-tender arthritis, which causes fever as well. Look into the mouth, look at the oral hygiene, just the general state of dentition. Is there any pharyngitis, Walde's ring? Is there any tonsillitis? In the eyes, you're looking for conjunctival, petechiae, choroidal granulomas, for rot spots, right, which are basically occur in the setting of infective endocarditis. They have a pale center, vasculitic lesion with a pale center, right? And look into the ears with the otoscope, especially in kids, because ENT infections are probably more common. Then, if it's an elderly person, always check for tender temporal arteries, because it could indicate temporal arteritis, which tend to be enlarged, tortuous, nodular, and non-pulsatile, right? Neck stiffness, very important, right? Especially a patient who complains of headache and photophobia. Check for neck stiffness, your Koenig sign, your Brzezinski sign, and just assess the general mental status and the high centers and orientation. Is the patient confused or corpus mentis? You check for any bony tenderness, any thyroid tenderness. Does the patient have a goiter? In terms of the heart, you want to ascertain that the patient has a murmur, especially in the setting of incompetence, right? So aortic and mitral incompetence. Is there a tumor? Bloop, right? Usually in the setting of atrial myxoma, which is the differential for mitral stenosis, right? Is there a loud pulmonary component of the second heart sound? Is there a pleural or pericardial rub, implying some degree of serositis, which can happen in infection, can happen in malignancy, can happen in autoimmune conditions. Chest, pick up if there's any bronchial breathing, if there's any effusion, if there's any dullness to percussion, implying some kind of consolidation or an infective process. In the abdomen, is it tender? Is there splenomegaly? Are there any lymph nodes you can pick up? Is there hepatomegaly? Is there loin tenderness, right, or what we call loin to groin pain, which happens with pyelonephritis or a complicated urinary tract infection? Is there bladder distension and any urethral discharge? Then take the rectal temperature if you suspect that there's factitious fever. Pelvic examination, perianal inspection. Don't forget to pass the speculum as well if there's a discharge, and also if there's any suspicion for cervical cancer, because you want to do a pap smear, right? And the legs check for any rash, example, erythema nodosum. I know the differential of erythema nodosum is wide, from infection to autoimmune conditions, right? And any ulcers, any web space sepsis. Especially, don't forget diabetic patient to rule out diabetic foot. Right? They may have an ulcer, they may have intertriginous infection. And the urine, check for the just the macroscopic appearance. Is it turbid? Do your urinalysis looking for leukocytes and nitrites, and stool examination for parasites. There's a lot of steps to cover. Okay, so obviously the etiology for pyrexia of unknown origin, or the possible underlying causes, is quite an exhaustive list. But just to mention a few, the big headings we certify them into is neoplasms, infections, connective tissue diseases, drug, fever, right? Miscellaneous and uncertain. So neoplasm is probably the more common ones we see: Hodgkin's, non-Hodgkin's lymphoma, especially if the patient has generalized lymphadenopathy, right? Even intra-abdominal and intrathoracic lymph nodes, para-aortic lymph nodes on imaging, leukemia, malignant histiocytosis. Important to do a smear on these patients to obviously look for any atypical cells. Other tumors can be hepatic, renal, lung, disseminated carcinoma, atrial if you hear the tumor, bloop, or if you hear the what sounds like mitral stenosis, okay? In the setting of HIV, guys, the most common malignancies is Kaposi sarcoma, lymphoma, and cervical carcinoma. So always be on the lookout for those, all right? Infection-wise, there's bacterial, there's viral, there's parasitic, and fungal. That's a nice way to certify. Bacterial, well, tuberculosis is endemic in South Africa, so something we always have to consider in the differential of anything, essentially. Brucellosis and other bacteremias, abscess formation, especially pelvic or abdominal, this is called anthracene Buten, right? You gotta investigate for these. If you're not sure what's causing the fever, endocarditis, or apply a modified Duke criteria. Make sure you get an echo and blood cultures, etc. Pericarditis, osteomyelitis, cholangitis in the patient who is jaundice, fever, right upper quadrant pain. So that's Murphy's sign. If you have hypotension, autopigmentation, that's Raynaud's pentad. Pyelonephritis in the patient who has a urinary tract infection, and now with loin to groin pain. Pelvic inflammatory disease, especially with cervical excitation, tenderness on examination. Prostatitis, syphilis, very important. Syphilis is a master of disguise. That is primary, secondary, and tertiary flavors. Lyme disease is not so common in our setting. Borreliosis is well, cash disease, which is Bartonella henselae. Dental abscess, always think about that. And viral things like infectious mononucleosis, EBV, which has links with many conditions, including autoimmune leukoplakia and lymphoma. CMV infection, hepatitis B and C, HIV, of course, infection, right? Parasitic-wise, talking about strongyloides, schistosomiasis, probably common in our setting. Always do stool and look for those ova. Right, malaria as well, very important. Patients who are hemolyzing together with a splenomegaly, together with fever, do your malaria rapid, okay? Q fever, toxoplasmosis as well. Fungal-wise, we talk about cryptococcosis, especially in the setting of cryptococcal meningitis, histoplasmosis, blasto. Connective tissue diseases, juvenile rheumatoid arthritis, which is basically called Still's disease. Then we got the adult flavor of Still's disease, systemic lupus erythematosus. Vasculitis in the way of GCA and PAN, immunosuppressive drugs, right? Drug fever, probably one of the most overlooked classes of causing fever. Anticonvulsants, antibiotics, allopurinol, heparin, that's classic example. But then miscellaneous, we have IBD, which is ulcerative and Crohn's disease, ulcerative colitis, I beg your pardon, and Crohn's disease, acute alcoholic hepatitis, granulomatous disease in the way of sarcoidosis, multiple pulmonary emboli, especially even patients who has risk factors, pulmonary embolus, right? So they have thrombogenic risk factors, they had a previous DVT, they got a malignancy going on, they're a smoker, they're taking oral contraceptive pills, etc. Thyroiditis, adrenal insufficiency, pheochromocytoma with paroxysms of headache and palpitations and sweating, familial Mediterranean fever, was somewhat less common in other hereditary periodic fever symptoms, hematoma, factitious fever. Okay. Some questions you want to ask a patient who has fever, and of course note the very important one. So have you had shivers and shakes, which suggests bacteremia, also suggests malaria, right? How long have you had your high temperatures? Have you taken your own temperature? How high has it been? Has anyone had a similar, had a similar illness? You're thinking about something contagious. What medications are you taking? Have you been through the list of those meds which are responsible for pyrexia? Have you had any recent illnesses? Have you had any recent operations or medical procedures? Have you traveled recently? Where to? Do you take any antimalarial prophylaxis and have the recommended vaccinations for your trip? Have you had any pets? Have you been sick lately? Differential diagnosis for prolonged fever and a rash. So think about viral, bacterial, non-infective. So non-infective things like drugs, lupus, erythema multiforme, which may also be related to underlying infection, but the big role plays in terms of viral is infectious mononucleosis, which is Epstein-Barr virus, rubella, dengue, bacterial virus, syphilis, and Lyme disease. Okay, my friends, the book of Hebrews chapter 11 is the big chapter that speaks about faith. And verse 6 says, without faith, it is impossible to please God, because anyone who comes to him must believe that he exists, and he rewards those who earnestly seek him. Grace is divine enablement that God offers to us as his children. So I think of it as grace being God offering his hand down to us, and faith is our response. It's our hand going up to meet his hand. So we receive grace through faith, and the key is via humility. But remember, without faith, it is impossible to please God. Have yourself a lovely day. I'll see you soon with another helpful video in this series on this channel. God bless you.